Healthcare in America is a lot like the weather has been here lately in Chicago. I think, 2-3 days ago it was 80 degrees and now it's 30 degrees. And unfortunately, healthcare has been about unpredictable as that. Surescripts, and maybe I should introduce myself. I'm Frank Harvey. I'm CEO of Surescripts. But Surescripts is a mission-driven healthcare company. A health information network is really concerned about some of those challenges we've seen in healthcare. And we've got an excellent panel today that's here that's going to talk a lot about that. But let me talk a little bit first about some of the things that are really troubling us. I think most of you know that the prediction is by 2034, there's going to be a shortage of over 120,000 primary care physicians. That's dramatic, 120,000 shortage. In addition to that, this year, over 30% of rural health systems are in danger of closing. That's this year. By 2040, it's estimated that 22% of the U.S. population will be 65 or over. And once you hit 65, 85% of us will have some chronic condition. 60% will have 2 chronic conditions. So what we're facing are 2 things. First of all, a shortage of healthcare providers and a growing need for healthcare recipients. Those of us that I'm rapidly approaching 65 myself, hopefully I can avoid those chronic diseases, but many of us don't. Fortunately, during the pandemic, there was some good news. There's one healthcare professional that has not only the ability, but also the desire to really practice at the full scope of their license. I think all of us know one of the heroes of healthcare were pharmacists during the pandemic. And so everybody says, okay, we've got all these pharmacists across the country, problem solved. Well, unfortunately, it's not that simple. There are really 3 things that we need to make sure we get in place that pharmacists can practice for the full scope of their license. First of all, on both the federal and state levels, we need to make sure that pharmacists are enabled or their practice guidelines are codified so we can continue to practice at that level. Fortunately, yesterday, HHS continued to extend the privileges that pharmacists were given during the pandemic for limited prescribing, the ability to immunizations and testing. So that was really good news for us, and we need to see that continue to expand. Secondly, we need to make sure that reimbursement structures are in place for pharmacists, both on the federal, state, and private. The health plans need to ensure that pharmacists are compensated for the time that they spend being this more enabled member of the healthcare team. And third, it comes to interoperability. That's where Surescripts helps play a large part as the leading health information network in the world. Last year, over 21.7 billion transactions across our systems. Mickey Tripathi and the group at ONC are doing a tremendous job to continue to move interoperability forward. Unfortunately, pharmacy is one of those areas that was left behind earlier in interoperability, but we hope to help be one of the companies that are helping to move it forward. Having 21.7 billion transactions, there's a lot of insights that you can really pull out of that information. And so we're presenting a paper at the conference this week that'll give you a number of those insights, but I'd like to talk to you just about 2 of those. First of all, when you look at the population, the geography of the U.S., there are 3,233 counties. Okay? A lot of counties, never really thought about it that way, but that's a good number of counties. Unfortunately, nearly 50% of those counties, there's less than 1 primary care physician for every 1,500 patients. Think about that for a minute. A concierge physician that'll do his private sort of panel of patients will take somewhere between 300 to 500 patients. 300, they say they can provide extraordinary care. 500, they'll say, that's about the limit where I can provide really good care. So in almost half the counties in the country, more than 3 times that many patients physicians have to see. And it's almost a failure of our healthcare system, and it's who's to blame, we're all to blame. It's just sad, particularly when you look at the health inequities created in the rural areas and some of the inner city areas by the shortage. But there is some very good news, and 61% of those locations that have less than 1 primary care physician for 1,500 patients, in 61% of those, there's a supply of pharmacies and pharmacists that are willing to practice, be an active member of that care team, to practice at a higher level across the full scope of their licenses. And we are really honored today to have with us a very esteemed panel that's going to talk about how in their organizations this evolving care team are being seen and your reactions and what you're doing to respond to it. So I want to thank everyone, first of all, for coming out in such a cold morning, so early in the morning. I know it's going to be a long, exciting day, but thanks for being here, and I'm really excited to hear our panelists today. Colin, why don't you take it away?
All right. Good morning, everyone. I'm Colin Hung. I'm an editor at Healthcare IT Today, which is a very fancy way of saying that I'm a professional conference goer. So I get to go to about 40 or 50 of these a year. So I love being in these hotel rooms and talking to all of you. It's a lot of fun. And one of the things I love to do at conferences is attend panels because we get quite a diverse set of perspectives. So hopefully bring that forward to you this morning. Also, my job is to try to keep it a little fun, a little light, because it is so early in the morning. So on the panel today, unbeknownst to them, I'm actually going to score them. And whoever gets the highest score is actually going to win a prize that's underneath my chair here. It is a bottle of maple syrup directly from Canada, which is where I'm from. So it's Canadian maple syrup underneath. So whoever scores the most points, you'll get the bottle.
Pressure's on.
So first of all, we'll have the panel introduce themselves, and I've warned them already that I will give them a question they have not heard yet. And so if each of you could introduce yourselves, the organization, your role, and if someone was going to play you in a movie, who would that be? And no judgment on who they pick. So if anybody wants to pick Ryan Reynolds, go ahead. It's fine. We'll start with you.
Thank you. I'm Eric Weidmann. I'm a family doctor, and I live in Austin, Texas. I'm the Chief Medical Officer with CompuGroup Medical. And wow, I have a weak point of not being able to choose because I don't know a lot of actresses.
It's okay.
But, this new version of Brad Pitt.
I like it. Okay, I like it. I can see it. I can totally see it.
So I'd go for that.
Brad
Thank
Pitt's
you.
good. That's a good one.
Very good. Good morning. Good morning. I'm Kevin Nicholson, Vice President for Policy, Regulatory, and Legal Affairs at the National Association of Chain Drugstores. We represent 40,000 chain pharmacies nationwide, and our member pharmacy companies fill over 3 billion prescriptions a year. I have been with NACDS over 20 years, and I am originally a practicing pharmacist in the chain environment.
Great. My name's...
Wait, and you didn't pick your You tried to dodge it. That's minus 5 points right now.
All right. Oh, -5. Oh, I'm in a hole now. So who would I want to play? So I was thinking that an age-appropriate person would probably be like Jude Law.
Okay,
right?
Jude Law, all right.
But I would like to think that it would be Ryan Gosling.
Oh, okay. All right. Good. Both good choices. Both good choices. Anita.
Good morning. My name's Anita Patel. I'm the VP for Pharmacy Clinical Services for Walgreens, overseeing our 9,000 stores in terms of the clinical services that we're offering, and very excited to be here for this panel, right up my alley in terms of what we're trying to do in changing healthcare. Do cartoons count?
Cartoons can count. Cartoons count.
Actually, I think I'll go with Mila Kunis because there's a height thing going on that I can relate to and the
great.
longer hair. So I'll go with that.
That works.
Great choice. Great choice. And Frank, we can't forget you.
Yeah.
So.
Oh, definitely. I'll definitely. Well, I'm a pharmacist by training, so I've been in healthcare for 40 years. Honored to be a member of the Surescripts team as their CEO now. I really like that question. Brad Pitt was always my answer. Not that I look a thing like him, or he doesn't, fortunately, doesn't look a thing like me. But I guess I've got to go with Ryan Reynolds since, all the other heartthrobs have been taken so far. So.
Nice. That's got to be 20 points for the two of you for naming Canadians. So that's good. That's good. So
I'm back.
You're back. You're back. You're in the positive territory. That's great. That's great. Just for the record, so I answer it, I would pick Seth Rogen only because he also thinks he's funnier than he really is. So that would be representative of me. All right, so first question. We are, all of us here in healthcare, facing a tremendous amount of challenges. We got the workforce challenge, we have the economic challenge. Frank, you mentioned we've got a looming physician challenge. And that doesn't seem to be ending anytime real soon. Paradoxically, it's times of challenge where a lot of change happens. It's forced upon us, so we would say thrust upon us to change. In the next 5 years, what changes do you think we will attribute to this time and say it's because of this time period that this change has now happened? All right. Anita, we'll start with you.
Great. So a couple thoughts there. Coming off of COVID, this was a time where, as Frank mentioned, the authorities that allowed pharmacists to be able to practice were nothing like we've seen before. But we were able to step up to the challenge of that. So for 2.5, 3 years, we've had this steady drumbeat of, if you're not sure what you have, you can go to a pharmacy and get tested to take the next best health action. We had over 200 million vaccinations occur within a pharmacy setting, just changing the ability to access for vaccines and closing care gaps. That as the foundation and that trusted community access, I think puts us in a great place to be able to position in terms of what we're seeing for primary care. The biggest thing here is we're not talking about complicated care services. We're talking about low acuity, very basic care that through COVID, it's been seen, the population was disproportionately impacted. Why was that? Because you had a subset of the population that just wasn't healthy. We're at a point in our history where we have a very great sick care system as opposed to a true healthcare system. So I think the conditions are set right now for this change to happen. The authorities are in place and the proof points have been given that we can start leaning into this differently. So as I think about where we're going 5 years from now, building off of this foundation, it's a critical juncture, being able to really focus in on being part of the overall care team. Again, the full scope of license, you'll notice we're not talking about the top of the license. This is truly, a couple decades ago when I went through pharmacy school, we're talking about the same type of foundational training and building off of that. So I think there's a lot really focused on low acuity care and being a complement to the overall care team.
Excellent.
Kevin, what are your thoughts?
Well, actually, I want to build upon what Anita said. And I really like what you said about there's a great foundation that has been established. Unfortunately, it happened because of the pandemic, but pharmacy did step up, and pharmacies were open 24 hours, 7 days a week. Patients had nowhere else to go. They could go to their pharmacy and receive care. They could get their vaccinations. Chain pharmacies have provided over 300 million vaccinations. We've saved billions of dollars in healthcare costs. We've saved millions of lives. So, as Anita said, the proof is there that pharmacies can do it, and we, so long as we're allowed to practice at the top of our license. So I think, Colin, we've already started moving on this 5-year path, and so we are at NACDS. Our goal is to build upon that. We are continuing to work, with members of Congress to allow pharmacists to be considered providers under Medicare Part B. Pharmacists are one of the very, very few providers that are not considered providers under Medicare Part B. So that is a huge gap that all of the pharmacy profession, all the pharmacy organizations are working, federally to close. Also, we have been and we are continuing to work in the states to expand pharmacist scope. It's a state-by-state process. It's very challenging. It's a lot of work. Again, we had already started working on this after H1N1, and we now have the empirical evidence that shows that pharmacists can do this, that they should be allowed to do this. And when I say we're working to expand pharmacist scope, I don't want, like as Anita said, I don't want to, give any impressions that we're trying to move in on anyone else's profession or territory. We are working at a state-by-state level, community by community, to expand scope, to provide services that are needed in those communities. So it's not like we're coming top down, this is what has to happen in these states. We are working at the local level. NACDS is working with the local pharmacist association. with our local partners, and we are slowly making changes. And that's why we are so pleased when HHS announced that they are extending pharmacists' privileges another 1.5 years, because we at NACDS have been begging them, I mean literally begging them to do this for well over a year. Well over a year. We've been sending letters, we've been calling them, so they finally did this, and this gives us and it gives the states more time. It gives the state we have a whole another legislative year now to work in the states to advance pharmacist scope.
Dr. Weidmann, what are your thoughts?
I have a bunch,
Okay.
and I'll share a few. You know, pivotal change commonly comes after major crisis, war interventions, economic collapse, pandemics, disease. And so the resistance and the disruption has really created an opportunity that you're taking, appropriate advantage of and trying to further the ball rolling forward to distribute, I think, the healthcare delivery load, burden, opportunities, whichever side of that ball's rolling on you or with you. And I have enthusiastic trepidation.
Okay.
And here's the thought. Low acuity visits, you only know are low acuity visits after the problem's resolved. So the idea of practicing at the top of your license is a concept for pop health. I like it. I'm all in. I really am. And it has thorny exception handlers. So in my job with medical software, my mind is always going to the exception handling. How do we handle the things that are outside the expected, the norm, the routines? So I'm enthusiastic about team management. I have trepidation about how we manage the support for those teams to deliver care in a climate that is still based not on pop health. Our legal climate is still based on individual rights, individual outcomes, and guaranteed, the one thing in life is we all have an eventual bad outcome. So again, I'm all in. I have trepidation. I'd like to see how we're going to navigate this because it will be a rocky road, I foresee.
Nice. Great answers. You score 5 points for using trepidation in the proper sentence. Anita, you get 20 points for expanding, saying you expand care and using the word sick care for the first time. That was good. And Kevin, you get -5 just because. All right. So we've been talking about alternative care models for a long time. And here at HIMSS, value-based care has been seems like a perennial topic for the last 5 years. We clearly aren't there yet. My question to the panel is, are we finally making meaningful progress towards any alternative model? And if so, do you have an example you can share with us? So are we making any progress at all on this road? Kevin, we'll start with you this time.
No, thank you, Colin. Yeah, that's a good question. And value-based care, it's been around a while, and so the question is, are we making progress? I think we are, and I'm hopeful that we will continue to make that progress. I think a good example, unfortunately it doesn't include pharmacies, is the MACRA, the federal, Medicare program where, they're using value-based care to deliver care for Medicare Part B patients. Unfortunately, we've been left out of that, but we at NACDS, we're making the case for, and I think, again, we have the empirical evidence now, we're making the case for why pharmacists and pharmacy should be included in these value-based care and managed care models. Pharmacies provide, it's shown, we provide quality care at a lower cost. We are the most convenient. Approximately 90% of Americans live within 5 miles of a community pharmacy. 90% of the individuals who have gone to a pharmacy, 90% of individuals who go to pharmacies visit those pharmacies 10 times more a year than other healthcare destinations. So we have the convenience, we have the value, we have the ability, we have the evidence. And at NACDS, we've actually developed a model for including pharmacies in value-based care. We've been talking with CMMI about including pharmacists in a CMMI model, and I think progress is being made, and I'm hopeful that we can do a better job of recognizing the value of pharmacies in helping provide that care more efficiently.
Dr. Weidmann?
So I'm not sure exactly how to pursue a clean answer to what you'd like to do.
That's all right.
So the value-based care topic, again, jumping from a fee-for-service to a value-based care is another huge disruptor. And I don't think even COVID was that big of a disruptor to make an entire healthcare system be willing to take the leap. Mm-hmm. So there's a transition plan. Okay. So what I look for and what our organization on our software is firmly rooted in is trying to provide people tools that they can keep a foot in both camps. Survivability of fee-for-service and awareness data feeds that give us value-based data to make decisions at the point of decision-making, not retrospective, not reviews. So empowering providers to move forward in a value-based care model with gap closures, with data systems, and the very challenging move to include enough clinical data interoperably that we can share with larger care teams. That will be a key to make an equation of a healthcare system shine, is we need to be able to give meaningful data and receive it in a way that makes decision points at the moment of care facilitated. So one of the things that has really come forward over the past 10 years is the awareness of prescription cost. Now that clearly has met maturity. It's in place for most providers across our entire country. Whereas 10 years ago, literally single-digit percentages saw in real time at a point of care a cost of a prescription. And 20 years ago, nobody knew it. Nobody knew what it was going to cost their patient. So that is a huge leap forward. And again, it's not exactly the moniker of a packaged value-based, but it is so integral to value when you're choosing something for a patient and expecting it to be deployed or not because of cost, or looking at cost to outcomes benefit.
I like it. Seems like a pretty definitive answer to me, actually, what you get. Anita, we'll go to you, and then we'll go to Frank at the end.
So Colin, in my mind, this is like 3 concrete things that are coming to life, right? The first is commitment, the second is focus, and the third is data. So from a commitment standpoint, with Walgreens, for example, we've made investments with Village and with Summit, with CareCentrix to really start meeting the patient across the care continuum as we're adjusting our community pharmacy model. So all of that combined starts providing a different kind of value-based opportunity for patients, coordination with payers, with healthcare systems, to be able to adjust how we show up and how we engage with the patient and where and when. It's on-demand care now. So how do we shift the delivery model as well as part of this. The second area is around focus. We don't have to boil the ocean. This is pretty straightforward. So we've started down the route of building off of existing infrastructure. So take COVID, for example, take testing. It used to be this thought of, I need to go get tested so I know if I have X. What we're trying to do is shift it to say, I'm sick, what do I have? So that small shift in multiplex testing, flu, COVID, what else can you add to that? Strep, RSV, so that you can actually have an answer when you have sick season so that you can take action. The other components like hypertension, blood pressure, just simply knowing where you are. You can't do anything if you don't know where you are. So definitely agree where you've got to first know, we've got to create a system where you can first find out what is my status and then the follow-up of what do I do next, how am I doing? And all of that needs to be shared across the care team. So when we think about data, there's two components of data that as we think about value-based care are super critical. Sharing of information, how quickly can you share it? And what do you have to share? It's not about all of the data that's out there, it's the key metrics, the key elements that you need in order to be able to care for a patient or to exchange information. The other is outcomes driven. How do we measure outcomes? What does good look like? And how do we really know the health of that individual patient? So I think where we are now with the three components of commitment, focus, and data, building new programs, new offerings to patients that are truly value-based, I think is what's going to make the difference in overall health.
Excellent. Excellent. Frank, what are your thoughts on this one?
Well, it comes down to the communication piece, and I think all of you have touched on a little bit. The need to have the right information at the right point, at the right time when you're faced with the patient. And that's where I think interoperability is making a huge change to us. The drive by Mickey and the folks at ONC having really promoted interoperability. The first wave of it, pharmacy really got left behind. They weren't really included. The pharmacy operating systems weren't as integrated in that. And I think we're going to see, again, an important point will be that pharmacists do have that right information. Just look at Paxlovid. For Paxlovid, pharmacists were given very early on the ability to prescribe and dispense it, but many pharmacies didn't have the right clinical information to be able to make those decisions. And so I think what we do from an interoperability standpoint will empower value-based sort of arrangements to be put in place.
Love it. Love it. All your answers are fantastic, so all of you get 20 points. So
what's the current score? Well,
now you're going to test me.
40.
You got 40. Anita's got 40. Kevin's got like 30, and you've got 35.
Okay.
35.
All right.
Yes.
Amy,
There you go. There you go. Got to do math this morning. That wasn't on the description, by the way, of the host. Okay. Well, since you brought it up, Frank, let's go to that question around interoperability. We hear a lot about interoperability. Obviously, here at HIMSS, there's an interoperability showcase, but a lot of times it's interpreted as the sharing of data smoothly between healthcare providers, like mostly hospitals here. What does interoperability mean to a pharmacist? Like, what does that practically mean when we say, hey, we want interoperability and want to extend that to the pharmacy? Like, yeah, give us an explanation of that. So we'll start with you, Dr. Weidmann.
Well, I'm not a pharmacist, so
Okay.
it's odd to start with me, but interoperability that I would like to see as I envision a pharmacy care team, which, Medicare opened this opportunity for a clinical care consult pharmacy operation some 15 years ago.
Okay.
Mm-hmm.
Does anybody have any awareness that actually is thriving in any nook, cranny of the U.S.? I don't think it is. Right? Okay.
Right.
So it's splatted because of infrastructure failure, frustration, time, reimbursement, all the above. It was just it's a great idea, and it was set up for failure. So what does it look like? Paxlovid's point, to simply have an accurate med list and a serum creatinine is all that the pharmacist needed to manage that, unless they were guided by their legal team and worried that, so this is my point on how to break down some of these barriers. What do they need? If it's focal things like Paxlovid, that's an easy reach. If it's now the ability to reach out into the health data network for that specific patient and grab specifics, we are so far from there. Because again, that kind of nebulous, I've got a new challenge and I'd like to grab these data points from the healthcare ecosystem, that would look daunting with current technology, but not impossible. So what would it look like and what do we need to do? We need to have some ability to create some data pools that have meaningful access without hobbling restrictions. We need to have some ability to assure people of their privacy and their skepticism about profiteering and scraping their data and moving forward. So what would it look like? It would look like a data pool that we could all access and feed.
I like it. I like it.
So Eric, can I just
Yeah,
build on that a second?
totally,
So
Anita.
I think the piece here is, what are we talking about in terms of volume of data?
Yep.
For pharmacists to be able to operate, it's really basic data and information on that individual patient. Again, we're not trying to do complex care services. We're trying to be a complement to primary care. So in that vein, we're talking about a smaller subset of data and information exchange. The most important thing is, can we make sure that that primary care provider, the next healthcare team member has the information they need to take their next actions? So communicating with the patient, there's a digital component there, interoperability component with other care providers, but we don't need all of that data. And so how do we set up a structure that allows for quick, rapid information exchange based on the basics of that individual's health and movement of information to who needs it? Mm-hmm. So I think that's the other piece is, how complicated are we trying to make this? How simple can we make it so that we're really thinking about what do you need in order to do your job?
I like it. Frank, what do you think?
Yeah, I've got to jump in on this one. I mean, we really feel like we can partner with healthcare to help be a solution there. I mean, just this past year with our product record locator and exchange, over 1 billion transactions, 1 billion records were sought out, brought in to help with treatment. That just needs to be extended to the pharmacy side as well, as effectively. But again, the ability to upload, to be able to download the specific data. And it's not boiling the ocean, like you said, it's a discrete data set that's needed to provide these functions we're looking for. So we really want to be a partner and a solution to help the industry move forward in this. And I think we've shown with either a clinical direct messaging, with over 1 million practitioners in the past year have used clinical direct messaging to provide messages back and forth rather than having to fax or to phone. To create more efficiencies there. And then with record locator and exchange, we're already part of the way down that road. So we're really excited about the opportunity to enable pharmacy to be able to practice at this level.
You ready to put it to the next level and put some sorting AI and data analytics to that
Absolutely.
RLS?
That's a piece of it,
Okay.
absolutely. And there's our Chief Information Officer and our Chief Technology Officer in the room, so they're both ready for that.
All right.
All right, Kevin, take us home. What do you?
All
what are your
right.
thoughts?
Well, I want to use a word that was used on Schitt's Creek,
Oh, okay. All
Canadian
right.
show. Maybe I'll get some points.
You get some points for that.
All right.
The Canadian show. I give you
Canadian
points for that.
show, okay.
With all I've been hearing, my mind is just bombulating with ideas now. But so I think Frank made an excellent point where pharmacies, ironically, have been left behind because pharmacies actually were the first member of the healthcare team to become truly electronic. When I was practicing, when I was a pharmacy student back in the 80s, we were electronic. Mm-hmm. We established with health plans the ability to, when you go to a pharmacy, I mean, what other healthcare provider can you go to and you know at the point of sale what your copay is, and you know that that the claim is going to be paid. You know, everything is all settled at the point of sale, and it's done in real time. The pharmacy is paid in real time. Everything occurs at the point of sale. Pharmacy was the first to do this back in the 80s. So I think it's really ironic that even though pharmacy was the first to start doing this, and again with e-prescribing, we were, with Surescripts, we got the e-prescribing going with Surescripts ahead of everyone else. So it's ironic that we were left behind and that we weren't included in the meaningful use that ONC, meaningful use provisions at that ONC. But so I agree. Because of this, there is fragmented data, and I think part of the problem is that you have, and it's more like. Part of the problem is sort of a technology standards problem. I think a big part of the problem is that pharmacy, almost because of the fact that we've been doing this forever, we use a completely different standard set than everyone else. We use NCPDP standards. Everyone else uses HL7 or X12, and there's a problem. It's hard for those systems to talk to each other, and you have to pay vendors to translate claims, and so that's a big gap. But that's something that definitely can be overcome. And I want to point out on your table there is a white paper that was recently released by Levitt Partners that was funded by NACDS that talks about the promise of pharmacy data interoperability. And Levitt Partners talks about the value that pharmacies provide, that that we've made progress. Pharmacy has made some progress, but more work needs to be done. And they provide recommendations for other members of the healthcare team, and as well as state and federal policymakers to help achieve interoperability. And I think Anita made a good point. It's not boiling the ocean. It's providing healthcare providers, the pharmacy, the physician, the hospital. It's providing them what they need for that patient, right? It's not the complete data set. It's what do you need to make sure that you have that patient's full set of relevant healthcare data. And I think, again, I just want to close with saying, we do have a fragmented healthcare system, but I think we're all working together to get all the different constituents connected together. And I think Surescripts is in front of that.
Great.
And has been.
Awesome. You get 10 points for Schitt's Creek reference, but I have to say Anita gets 20 points for pointing out that interoperability for pharmacists doesn't mean the entirety of the medical record, which is normally what we think about when we hear that word. So congratulations, Anita, you got the 20 points.
All right.
I'm going to get to my final question, but we have time at the end on purpose for any questions from the audience, so get your questions ready. You will score points too if you ask a question.
I like maple syrup a lot.
For the record.
If you like maple syrup, I like maple syrup.
But just my closing question is this. All of you have spoken about this new world where we have clinicians, physicians working hand in hand with pharmacists, and how pharmacists aren't really out for anyone's job. By the way, I use two words that have a Canadian accent, just so you can. So what does that ecosystem look like? What does that future look like in terms of a pharmacist practicing at the full scope of their license alongside their clinical partners? Describe what that world looks like for us that maybe aren't as close to that. Frank, we'll start with you and we'll come down the row here.
Well, I can tell you it's been going on in health systems for over 40 years. When I was in pharmacy school, one of the rotations you did was working hand in hand with physicians and nurses and the whole care team. And there were pharmacists that had limited prescribing practices at that point. So in the individual health systems, when you're in that ecosystem together, it works. So what we have to do is expand the technology enough so we all feel like we're inside that same ecosystem to make it work.
I like it.
That's
Anita.
worth 20 points.
That's worth 20 points? Okay, all right. I'm not sure lobbying for points is how this is supposed to work.
Well, she's in the lead right now.
So I'm going to take this one a little bit different. So when I think about where we're heading and like the vision for this, it should be really simple, right? So Colin, assume you have diabetes.
Okay.
So your diabetic patient complicated other medical conditions as part of that, you have never been controlled. Your doctor's asking you to take XYZ medication, you're not sure what's happening with it, where you're at, and frankly, you don't have time, it's not accessible, it's too hard to get to the doctor's office. And oh, by the way, for your doctor, your primary care, to provide all of the recommended services for you would take that person 26.7 hours. So they need help. So we can step in and help you. You come in, we take your hemoglobin A1C level, we figure out where you're at, we go through counseling, nutrition, do you need an eye exam, foot exam, what else can we do for you? And oh, by the way, we also know that you're hypertensive and that we can do your blood pressure check at that same time too. And then all of that information is shared with your primary care so that when you do see that individual, they can focus on the other areas of your care, really making you an overall healthy person. And by the way, all of that is in your digital record, and you can easily access it so you know your information, and you also have the right contacts to come back in to your local Walgreens, of course, to find that next best action that you need to take, and your coach. You actually have a healthcare team for you. So that's how we're going to change healthcare. Not by, oh, I've got blood pressure medication, I'm uncontrolled, I'm just gonna add, like polypharmacy is a problem in this country. So how do we make a person overall just better? And oh, by the way, I'm Canadian too, so I think that's 50 extra points.
Oh, wow, like that. I like this. Everyone's
You were
lobbying for
holding out
points.
the
I needed to see where I stood on the
Okay.
panel and
And then
the
you're going to pull
bonus.
that card at the end. I like it. I like it. Kev?
Well, thank you, Colin. I want to build upon what Frank and Anita said. I think it's a combination of first of all, I think there is a role for pharmacy in value-based care and in helping helping work as part of the care team to provide care, the most efficient care in the most cost-efficient way. But I think Anita also made a great point that pharmacists can also be part of the care team in a community-based care team where as a patient, as a consumer, you can go to your pharmacy to get your vaccine. You can go to get some simple tests, test and treat. You can go perhaps to have. In some states, pharmacists can prescribe medications that don't need a diagnosis, such as travel meds or oral contraceptives, or again with test and treat. You run a test. If the test is positive, you can provide the antibiotic for strep or the antiviral for the flu. Also, pharmacists and pharmacies, they help patients manage their conditions, as Anita mentioned. Helping patients understand their hypertension, understanding their diabetes, understanding their COPD, and helping them, even just helping them know how to use their inhaler properly can do wonders for adherence and for the ability for patients to really benefit from their asthma medication. So I think it's a combination of value-based care, but also just being recognized as part of the care team and and sharing the relevant data.
Dr. Weidmann?
I don't think this is new dynamics at all. This is old school. When Frank and I started in practices, we had verbal relationships regularly with our pharmacy colleagues around our neighboring pharmacies. We knew their voices, we knew their names, they hated my handwriting. It was all the typical things, but it was a collaboration and it helped us both work better at the top of our licenses. We're trying to apply that to a completely different age where, quite frankly, healthcare is depersonalized. We are now and will be, both on the medical side, the hospital side, the pharmacy side, your care will be delivered by people, but you will consider your care delivery route as doctor clinic, doctor pharmacy, because faces will change. And the care teams will act as teams working within infrastructure. So To me, it's how do we fit our current technology to do what was naturally the way it worked in the past.
Right.
And improve on that, because now we have volume, speed, accuracy, and other tech support to try to help that have less leakage, exception handling, adverse outcomes, and mistakes. And so that's the challenge, and why we're all sitting up here from different perspectives and seats, working on the same project.
I like it. I like it. Great answers from all of you. 10 points for everyone. Anita does get the 50-point bonus for being Canadian. Okay, now it's time for questions from the audience for this esteemed panel. Does anyone have a question they want to pose to the folks up here? Don't be shy. It's not church. Yes, sir.
Are you seeing the change of pharmacist training in their education? So as they leave their education, they're expecting a career where they're going to be much more involved in the care? Like, is it changing in their training now?
Ooh, great question. Is pharmacist training changing to reflect this new reality we've been talking about? Who wants to take that first? Anita, go ahead.
Go ahead.
Okay, I'll start and then please build on this. So a couple things. So the activities that we're talking about, this is foundational, right? This is bread and butter. Pharmacy is an interesting profession, one of the few where you go through training, but your scope of practice post-training is not the same as your training. It's kind of fascinating when you think of it that way. Imagine telling a doctor, imagine telling a nurse, by the way, you're not going to be able to do half of what you were trained to do. So I think the foundational components of the training are there. We always need to be able to refresh, build. I think the digital environment is totally different, and that's courtesy of COVID too, just accelerating that. We need to make sure, and we're working with the schools of pharmacy to outline what it is we're going to look like. Now, part of it is on us as well. What can we do to adjust our operating model so that it's not about tactical dispensing activities? So we've taken, for example, an initiative called micro-fulfillment. It allows us to take some of the tactical acts of dispensing out of the workflow, freeing up time for pharmacists. We've adjusted our performance measures so that you're no longer stressed about meeting a metric, instead can concentrate on that human relationship with that individual patient. So as grads are coming through and working as interns, they are seeing this come to life. But to your point, how are we preparing them for this alternative? We're also offering alternative positions too. So centralized pharmacy services that provides a different kind of non-dispensing support to pharmacies. That's been live for us for almost a decade. So lots happening. The training's there, building on it, refreshers, the digital experience, making sure grads are ready for that piece of it, and then continuing to improve our operating model.
I love it.
Thank
Kevin?
you, Anita.
Yeah.
I would add that I definitely believe that the schools, the pharmacy schools, are preparing pharmacists for this new world. Speaking personally from my own experience, I graduated pharmacy school many years ago, and I can tell you that the young pharmacists I see coming out now, have had a much different training, and are far more excited, interested, capable of providing services, providing cognitive services. And Anita made the point that that pharmacists often, they come out of school and they sometimes are put to an environment where what they're doing is not exactly what they were trained to do, and that's and at NACDS we are looking to address that. We believe that actually a lot of the work that pharmacists do, pharmacy technicians could do. And actually we see with COVID, we see that the federal government has recognized that pharmacy technicians can provide COVID-19 and flu vaccinations. So, and we're working in the states to expand not only the scope of practice for pharmacists, but also for pharmacy technicians, because pharmacy technicians are very well trained, and if we can allow them to provide some of the, to perform some of the activities that were traditionally delegated to pharmacists, then we have more opportunities for pharmacists to, practice at the top of their profession.
Zero insight into that.
Zero. Frank?
Yeah, I'll give a little bit. I was fortunate. I went to Medical College of Virginia, and it's a multidisciplinary pharmacy school. In other words, we practice with dentists, with physicians, with NPs, with PAs, with the med techs, rad techs. So we were all sort of together in there. So through our training, we became very accustomed to working as a practicing team. And in Virginia, for a long time, there was only one pharmacy school. It was Medical College of Virginia. So all pharmacists generally coming to the state practiced that way. When I got out and I was practicing as a pharmacist, it was, every day I would have physicians call me and really consult. This is what I'm looking at. What should we, how should we, treat? What do you think? And, that was pretty common. Now that went away, and more pharmacy schools were stood up, and they weren't associated necessarily with medical schools. But I think I see the training now. All of those pharmacy schools are really trying to integrate those individuals in with those multidisciplinary teams to ensure that they do know how to practice hand in hand with the rest of the medical care group.
Love it. That would be great. Sir?
Given that we have two Canadians on the panel, the question I have is, have we looked outside of the U.S. for other models of pharmacists operating at the top of their license to service their needs? I'm just curious if there's some learnings there.
Sure. I'll start with that one. Yes is the short answer. So I think when we look across globally what other countries are doing, scope of practices are expanded for pharmacists. Canada, no plug to Canada, but Canada, for example, both the actions that they did during COVID, extending Paxlovid responsibilities first. Also, it was a different type. It wasn't you must check labs X, Y, Z. It was very much similar to the physician's prescribing authorities. In addition, we're also seeing British Columbia, one of the provinces in Canada, also expand scope of practice for pharmacies to really get into primary care services. And we're seeing that trend across the country there. The UK also, again, infrastructure is different, interoperability with data is different. You're talking about a centralized healthcare system, truly a system. The systematic approach allows for that information sharing much more easier. And so you do see practices and scopes that are different in both Australia as well as the UK.
And they have a different medical liability structure as well.
Yes.
Which makes a huge difference in how corporate extension is willing to risk and take that on. So.
Yeah, I would definitely say a nice model is the UK. I mean, as much as I love the Canadian system, the UK model is probably, they have interoperability a lot further advanced than Canada has, but the way they've expanded the scope of practice for pharmacists was actually the model for the Canadian folks when they did that. So I'm not sure, someone from the CPHA was supposed to be here, are they? There she is, yeah. So the Canadian Pharmacists Association is actually here, so she probably could have a great answer for you in terms of looking at other models from other countries. So excellent, good to see you. All right, we got maybe time for one last question before we head out. Anyone else got a quick question for the panel? No? Okay. All right. Well, thank you to the two of you, 50 points for each of you for asking a question. And thank you to this esteemed panel for putting up with me this morning and providing such great answers and such great insight. And thank you to Surescripts for hosting this lovely breakfast this morning.
Yep.
All right. Thank you very much.
Excellent. Really good. All right.